Well, hello, everyone. My name is Dan Murphy, and I'm a physician assistant. And I'm here with an important guest, Dr. Robert Janda. He's a gastroenterologist, and we've been asked to talk to you today about some important topics in gastroenterology. And our first topic,
Good morning, Dan. Let me say hello to
okay,
everyone, to you and everyone. Thank you for joining us today. Uh, Dan and I worked together at Health Park Hospital in Fort Myers, and there were we've been asked by Florida Gulf Coast University to create a video with what we think might be some important topics related to gastroenterology. So here we are.
our first topic is titled a Clarion Call. So, Dr. Janda, what's the urgent message we wanted to convey today?
Well, Dan, you and I, when we encounter patients at the hospital, we see a lot of different liver diseases. In the past, we would deal mostly with patients with liver disease from, say, alcohol use, sometimes liver disease related to hepatitis, like hepatitis C or hepatitis B. But it seems as though that liver landscape is changing, and we're seeing more and more patients coming into the hospital with different types of liver disease. And specifically, there's one that seems to be increasing in prevalence called fatty liver.
Well, what is fatty liver?
Well, fatty liver is a very descriptive term. It basically refers to the excessive accumulation of fat in the liver. Normally, the liver is not designed to store fat. That tends to occur in other areas of the body. If we see that there's an excessive amount of fat in the liver, usually that's an indication of too many calories that have been getting into the body. Now we know that sometimes this can adversely impact the liver when we store too much fat in the liver. In years past, we would tell patients, well, you're just eating too much and you're overweight. So the best thing for you would be to try to lose the weight because fatty liver is completely reversible. Sometimes patients come into the office and they're with their primary care physician and they have some blood work done. And occasionally we discover that the liver blood tests or liver enzymes are abnormally elevated. And usually that's an indication of some sort of problem with the liver. And often when we look into this in greater detail, we discover that there may be too much fat in the liver.
Well, how common is fatty liver?
Fatty liver is very common. We estimate that 30% of the world's population has fatty liver, 30%. In some areas of the United States, it's even more common than that, especially in the Midwest or in the South, often as a result of dietary preferences in that population. But we recognize that fatty liver is increasing rather dramatically in the United States and worldwide.
Well, if fat accumulates in the liver and remains in the liver, can that eventually cause problems?
It can. So most people who have too much fat in the liver will live to 90 years of age with too much fat in their liver and never encounter a problem. But we now recognize that there's a subpopulation of patients who have this fatty liver condition where the excessive fat buildup tends to cause inflammation in the liver. So, of all our patients who have fatty liver, we estimate that about 20 to 30% will develop associated inflammation. When the fatty liver is associated with inflammation in the liver, that's known as a different term, which we now call MASH, M-A-S-H, it's just like the old TV show.
Well, I've heard that we no longer refer to the condition as fatty liver anymore. Is that true?
That is true. That is true. So the nomenclature has changed because we're learning more and more about what causes a buildup of fat in the liver. The newer term that's often utilized today is called steatotic liver disease. The term steatotic basically means fat. Now, in general, there are two common reasons why fat may build up in the liver. One common reason would be excessive use of alcohol, but another common reason would be related to an individual's underlying metabolism. So as we're learning more and more about fatty liver, we recognize that for a lot of patients with this condition, the steatosis of the liver, it's related to what we now refer to as metabolic dysfunction. So that there's something wrong with the body's metabolism that leads to this fat buildup. Now, fat cells in the body naturally can produce certain proteins referred to as cytokines. Cytokines. And cytokines do a lot of different things in the body. They help cells communicate with one another, but they also tend to drive inflammation. So if fat cells generate too much cytokines, we develop inflammation in the body. Now, inflammation in the body, as I'm sure many know in our audience, is not a good thing. When the body is inflamed, we recognize that it can affect our body's blood vessels. The lining of the arteries sometimes can build up debris and become harder. We call that arteriosclerosis, also referred to as hardening of the arteries. Sometimes that arteriosclerosis then leads to other health problems, specifically high blood pressure. So if the blood vessels are not soft and compliant like they normally should be, but rather more hard, there tends to develop higher pressure inside those arteries, which we refer to as hypertension or high blood pressure. Now, along with this metabolic dysfunction and this inflammation that affects the body, we also recognize that it can predispose to increased amounts of lipids like cholesterol or triglycerides in the body. We also know that it can reduce immune function in the body and predispose to infection. We also recognize that with this metabolic dysfunction, the insulin produced in the pancreas is not as sensitive in the cells, and therefore there's some predilection toward diabetes. So we've come to recognize a syndrome we now call metabolic syndrome, which is characterized by several of these changes that we mentioned, including obesity, including diabetes, high blood pressure, high cholesterol or triglycerides. That's called metabolic syndrome.
Well, how would a patient know if they have steatosis or MASH?
Well, that's a difficult question to answer because sometimes it's even difficult for us to know if someone might have too much fat or steatosis of the liver. Very often, this is picked up in an individual who goes to their doctor, has the blood testing of the liver, and we discover abnormal liver enzymes. Sometimes patients will require different types of imaging studies of the abdomen, such as a CAT scan of the abdomen, or MRI of the abdomen, or an ultrasound of the abdomen. And those tests are very helpful in determining if someone has a fat buildup in the liver. We also look for features of the metabolic syndrome. So if someone also has diabetes, they naturally are prone toward steatosis of the liver, or high blood pressure, increased levels of lipids in the body. Those are indicators that we may be dealing with underlying fatty liver. If there's suspicion that the liver contains excessive fat, many doctors, including primary care physicians, will order a very simple test called the FIB-4. FIB meaning FIB-4. The FIB refers to fibrosis or scarring. The 4 refers to the 4 parameters that are measured as part of this test. Now, when there's a buildup of fat, and if there is MASH or inflammation in the liver, that chronic inflammation can lead to damage to the liver cells. And although the liver has an enormous capacity to regenerate damaged liver cells and then produce normal liver cells again, it has a limited capacity to do so. So if this ongoing inflammation persists in the liver, over time, the liver may lose its ability to regenerate healthy liver cells and in its place leaves scar tissue. Now, when there's an excessive buildup of scar tissue in the liver, that can obviously lead to other liver problems. But if the FIB4 test is normal, then it's a pretty good indication that the liver is not damaged with any degree of scarring. If the FIB4 blood test actually is abnormally elevated, you have to worry that there may be some element of fatty liver with scarring in the liver.
Well, if a patient has excessive fat in the liver, can we determine that there's any inflammation going on associated with that, or MASH?
Right. So we can, and the first step, as I mentioned, would be the FIB4 measurement. That can be done by pretty much any doctor. Years ago, we would have to do biopsies of the liver as a way of determining if there's any inflammation or scarring consistent with MASH. Nowadays, we do have other types of non-invasive tests, since we just don't do as many liver biopsies as we did years ago. So there's a test called a FibroScan, which is an outpatient test that looks at the liver by sending ultrasound waves into the liver and measures how quickly those ultrasound waves are able to pass through the liver. Now, if the liver is normal, it tends to be soft and very pliable, and sound waves easily travel through that healthy liver tissue. On the other hand, if there is scarring or fibrosis in the liver, the liver becomes more firm, less pliable, and the sound waves are not able to travel through the liver as quickly. So the FibroScan is a measurement of how quickly sound waves may pass through the liver, and we can actually measure the speed of those sound waves to determine if there is any scarring in the liver and to what degree. Now, if there are also other types of tests that can be done. Sometimes we can do an MRI of the liver, a special type of MRI, which can measure the amount of scarring in the liver, similar to the FibroScan, but that's considerably more expensive than the FibroScan ultrasound test. There's also a blood test, a proprietary blood test called the FibroSure, which is a blood test sometimes helpful in determining the presence of scarring in the liver. Now, if that scarring in the liver were to continue over a long period of time, this can lead to cirrhosis in the liver. Cirrhosis simply means that the liver has been so damaged that, it's been largely replaced by scar tissue. Since we only have one liver to live on, if that liver isn't functioning properly, it will affect our overall health and well-being. And if that liver actually fails, obviously we won't survive that without liver transplant. So it's very important medically to determine if someone has any scar tissue associated with their fatty liver, because that's a harbinger of worse things to come. And that's something that needs to be taken care of, as quickly as possible if we identify that MASH is present.
Well, Dr. Janda, what if a patient has excessive fat buildup in the liver? Is there anything they can do to reduce that?
Yes, absolutely. And that's a good question, Dan, because that's an important question to answer. So we know that simple weight loss goes a long way at reducing the fat content in the liver. If you reduce the amount of fat in the liver is less prone then toward any scarring or damage also. So we often recommend that patients try to lose about 10% of their body weight, because studies have shown that a 10% reduction in body weight will not only help reduce or eliminate the fat from the liver, but it also can help reduce some of the scarring that may have developed in the liver related to MASH. We also recognize that exercise is very important. We've done studies where if patients just exercise on a routine basis. Even if they don't lose weight, the fat will come out of the liver. Part of that is because muscle is a great way to burn calories, and so even if the weight doesn't come off, just by burning more calories, that helps to reduce the fat buildup in the liver. So the most important thing is, reduced caloric intake, and also to try to increase our natural metabolism as a way of, resolving this metabolic dysfunction that contributes to fat buildup. In terms of reducing caloric intake, obviously, overall, less calories the better. Particularly, patients need to avoid carbohydrates. Most importantly, it's important to avoid processed foods, which are just in general very unhealthy for us, and focus more on really healthy foods, fruits and vegetables and so forth.
Well, Dr. Janda, does alcohol play a role in fat buildup in the liver and metabolic steatosis?
Yes, absolutely. So, alcohol, it does have a lot of calories and can contribute to too much caloric intake, but it also seems to predispose to fatty liver. In some individuals who have both metabolic dysfunction and chronic alcohol intake, there's almost a synergistic negative impact on the liver, in a sense that 1 + 1 does not necessarily equal 2 in that case, but 1 + 1 can equal 3, or 1 + 1 can equal 4 in terms of the damaging effects on the liver. So alcohol should be reduced. In women, we recommend no more than 1 alcoholic beverage a day. In men, no more than 1.5 alcoholic beverages per day. In addition, alcohol also is pro-inflammatory. So with this metabolic syndrome, we know that this is a pro-inflammatory process, which is only exacerbated by alcohol intake.
Well, if someone eliminates alcohol and they try dieting and exercise, and they still can't accomplish any weight loss or fat reduction, is there anything else they can do to reduce the fat?
Yeah, yes, they can certainly try harder because for some people, they don't really put the full discipline into their dietary restrictions. But we do often recommend a Mediterranean diet. We've recognized that a Mediterranean diet can be very beneficial in terms of reducing the metabolic dysfunction. I'm a big fan of intermittent fasting, where an individual would we eat 1 or 2 meals a day rather than 3 meals a day. As all of us get older, our caloric needs are reduced, so we don't need necessarily to eat the amount of food that we're accustomed to eating. Intermittent fasting works beautifully for weight reduction. I prefer that our patients eat just 1 meal a day rather than 2. And that 1 meal a day, should be a healthy, normal-sized meal, not trying to eat all the calories that they otherwise would have had at breakfast or lunch. But that intermittent fasting often will lead to weight reduction. And most patients, if they're well disciplined, will lose 0.5 pound to 1 pound a day. Obviously, exercise is a good way to build up muscle mass and increase our burning of calories. So that often is very helpful combined with reduced caloric intake. Over the years, we've developed various operations that as a one of the last resorts to assist in weight reduction. I'm sure some of you have heard of gastric bypass surgery, where surgically we go in and reduce the size of the stomach to maybe the size of a plum. And in that way, whenever someone goes to eat, they fill up very quickly. They don't want to stuff themselves. They feel uncomfortable, and therefore they tend to lose weight with that. Now, some people get around that. They find that, boy, if I just eat ice cream all day long, it doesn't bother me. I can eat as much as I want. I don't fill up. Well, they sort of defeat the purpose of going through that operation. But if they're disciplined in combination with that particular surgery, they often lose 10 to 20% of their body weight. There's a newer procedure called a gastric sleeve procedure, where again, it's an operation to go in and reduce the size of the stomach. Instead of making it just the size of a plum, they make it more a tube shaped, so that the stomach, again, can't handle the amount of food that it could at one time. Nowadays, we even are able to do that gastric sleeve procedure endoscopically, which is to say, a patient can come into the hospital, having a scope going into the stomach, where we can stitch close that stomach, reduce the volume of the stomach, and that usually works very well also. Nowadays, we've all heard about these GLP-1 medications, and this has really become a game changer for a lot of patients, because these are medications which help to reduce our appetite. They also slow down emptying from the stomach, so that when we sit down to have lunch, we may not be very hungry because we still have our scrambled eggs sitting in there from breakfast. That is, the process of stomach emptying is slowed by the GLP-1s. So with that, there's commonly some very good weight reduction, again, in some cases up to 20 or even 30% of normal body weight. The only downside to those medications is that there can be side effects from these medicines. And once you stop that GLP-1, there commonly is a tendency to regain the weight back.
Okay. Well, does weight reduction by itself, does that alter metabolic dysfunction?
Yes, absolutely it does. So we can reset the body's normal and healthy metabolism by weight reduction. And with that, you often notice that in diabetics, their blood sugars are much better controlled, even normalized, and in some cases that the diabetes can even go away. Individuals with high blood pressure will commonly notice that their blood pressure is much more easily controlled when they reduce weight, and with that, sometimes even get off their blood pressure medications. Individuals who have high cholesterol or high triglyceride levels often will see an improvement in those readings with weight reduction, and even to a point where they're able to stop their medicines that are given to help reduce the lipid levels. In general, patients will feel better with weight reduction. They tend to feel more alert, more energetic, and so it can have many benefits.
Well, if there is MASH in the liver and that persists, what happens? Can that cause anything?
So yes, absolutely. So we did mention earlier how sometimes that excessive buildup of scar tissue can lead to cirrhosis. Individuals with cirrhosis have a reduced life expectancy. There can be many complications that can occur in the body related to the cirrhosis, complications that we deal with in the hospital on a daily basis. We also recognize that individuals who have cirrhosis of the liver have an increased risk of cancer in the liver. So anytime the body there's an organ that has chronic inflammation, that increases cancer risk. So chronic inflammation in the liver increases liver cancer. Chronic inflammation in the colon increases colon cancer risk. Chronic inflammation of the pancreas can increase risk of pancreas cancer, and so forth. So inflammation is a bad thing. So we're focusing mostly on the liver today, but certainly reversing that metabolic dysfunction will improve and reduce the steatosis of the liver, as well as the scarring or fibrosis. Right now, of all the individuals who are diagnosed with cirrhosis, about 60% of them have underlying MASH to cause their cirrhosis. Again, this is much higher than what we've recognized years ago, and that risk is increasing. So right now, the number one cause of cirrhosis is MASH, and in fact, the number one cause for us to do liver transplant is no longer alcoholic liver disease, it's no longer hepatitis C, but rather it's MASH.
Well, I was watching TV the other day and I saw a commercial for a medication called Resdifra. Does is that used to treat MASH and how does it work?
Yes, yeah. In fact, I saw that commercial too, Dan. And right now, there are two medications that have been FDA approved for treatment of MASH. The first is called Wegovy, uh, which is also known as semaglutide. That's one of the GLP medications that we often use. Uh, there's another term for that. It's called Ozempic. Ozempic is the trade name for treatment of diabetes. Wegovy is the trade name for treatment of obesity. But basically, they're both semaglutide. They're both the same. There's the same medication. So the benefit of the Wegovy or semaglutide is that you will reduce weight, and with that, you will reduce the steatosis of the liver. The Resdifra that you mentioned, Dan, it works a bit differently. It doesn't necessarily contribute to weight reduction, but it has the ability to go into the liver and help the fat escape from the liver. So Resdifra will not only reduce the steatosis, but also the scarring in the liver. So I think is that all the questions you have about
On the fatty
fatty
liver,
liver?
that you answered a lot of questions. We really appreciate that. But we did have another topic that we wanted to talk about, and we entitled this "What Goes Down Sometimes Comes Up,"
Very good.
otherwise
Yeah.
known as GERD. So, what is GERD?
Well, GERD is a condition where stomach acid tends to come back up into the esophagus. We'll commonly refer to that as heartburn, or some people actually develop regurgitation, where there's a larger volume of stomach acid that comes up and even sometimes comes up into the mouth. So GERD is an acronym that stands for gastroesophageal reflux disease. Uh, that's a mouthful, so that's why we refer to that as GERD.
So, is heartburn the same as GERD?
Well, heartburn is the most common symptom of GERD. So heartburn is a symptom, whereas GERD is really more of a disease of the stomach and esophagus that can have a variety of other symptoms, not just heartburn. So some people with GERD will come into the hospital with chest pain, and we give them a thorough evaluation of the heart, and sometimes discover the heart is fine, but then you have to wonder if it might be GERD related. For other people, they have excessive belching. Sometimes the acid comes up so high into the esophagus, it gets into the throat and can cause a sore throat. Sometimes it causes burning in the mouth or the tongue. Sometimes we have dentists who send their patients over to the gastroenterologist because they're noticing that the molars in the back of the mouth are losing their enamel, and the patients are getting cavities in those areas because the acidity is coming up so high into the mouth that it's wearing the enamel off those teeth. So there's also something called a subtype of GERD called LPR, or laryngopharyngeal reflux, where with that the acid gets in the throat enough where they develop a lot of problems with coughing. Sometimes the acid spills into the lungs. They may have asthma exacerbation or wheezing because of that. And in some people where that acid reflux has been going on for a long time and spilling into the lungs, there too can start get inflammation in the lungs and scarring in the lungs. That's a condition known as pulmonary fibrosis. Now, not everyone with pulmonary fibrosis has that due to acid reflux, but we do recognize that that happens in some people.
No, doesn't everybody have acid reflux?
Well, a lot of us have heartburn or acid reflux from time to time. Um, there is one of the reasons that acid reflux can occur is because the valve between the esophagus and stomach is not working properly. That valve is a one-way valve, so that valve should open to allow our food to pass from the esophagus into the stomach, but that valve should close up and prevent any backup of food or acid or digestive juices to come back into the esophagus. Now, from time to time, we do naturally relax that valve. We call that physiologic reflux. So 4% of our day, that valve naturally will relax, and it does so as a venting mechanism. Whenever we eat food or swallow liquids, we take some air down with it, and there can be a buildup of gas or air in the stomach. And by relaxing that sphincter, those gases in the stomach will come up. Some people notice that as belching, but most people don't notice at all. Now, with that natural relaxation of the lower esophageal sphincter, there can be acid that comes up with it, but most people don't feel that to any degree. Now, certain foods we know can trigger acid reflux, particularly if we eat foods that have a high acid content, most notably coffee, black tea, cold beverages, anything with citrus like orange juice or lemonade, alcohol, even spicy foods, tomatoes and tomato products. All these things have an acid content and sometimes will trigger some heartburn for a lot of people. If someone overeats, they tend to produce more acid and slower emptying of the stomach and may be prone toward heartburn as a result of that. And also we've recognized that if someone has a meal late at night and goes to bed and lays down, sometimes that recumbent position makes it easier for the acid to back up into the esophagus.
Well, why does that happen?
Well, there are three common explanations for why people develop the GERD. We mentioned that sometimes that one-way valve, known as the lower esophageal sphincter, or LES, doesn't close properly. Now, sometimes that weakness of the lower esophageal sphincter occurs because of a genetic basis. That is to say, this GERD tendency sometimes runs in families. We also recognize that individuals who do a lot of heavy lifting, for example, weightlifters, often are suffering with acid reflux tendencies. Now, if someone does have some tendency toward acid reflux, naturally the esophagus should develop a series of contractions to push the acid back down into the stomach. Now, there are some individuals whose esophageal contractions are very weak. So even if they were to develop a little bit of physiologic reflux or natural or reflux of acid otherwise, the esophagus may not be pushing that acid back down. And as the esophagus is bathed in acid, they may start to notice that burning sensation. So in addition to a weakness of the valve, in addition to sometimes reduced esophageal function, thirdly, some people have poor stomach emptying. Now, in some individuals, their natural contractions of the stomach, which we refer to as peristalsis, may be diminished. And so when they have a meal, the food resides in the stomach for a longer than normal period of time. The stomach thinks, oh, there's food in here, let's make more acid. And so there can be excessive amount of acid production due to poor stomach emptying, and that excessive acidity might predispose to the acid reflux.
Well, Dr. Jane, now how common is GERD?
We've done studies that have estimated the prevalence of GERD to be about 20 to 25% of the adult population in this country. So it's extremely common.
Well, other than symptoms of acid reflux disease, can excessive GERD cause any other problems?
Yes, it can. So when the esophagus is exposed to increased amounts of acid, again, that can drive some inflammation in the esophagus. And as we mentioned before, inflammation is never a good thing. Sometimes chronic inflammation in the esophagus can cause scarring. Scarring in the esophagus, scarring which encircles the esophagus over time will cause some narrowing to develop in the esophagus because scar tissue naturally tends to contract over time. If the esophagus narrows, sometimes that can make it difficult for stomach acid or rather for food to get through the esophagus into the stomach. That's known as an esophageal stricture, which in some people, they need to have that stretched open with a balloon in order to allow the food to be able to pass more easily into the stomach. Now, when there's acid reflux that occurs over a long period of time, in addition to the stricturing that may occur in the lining of the esophagus, some individuals will develop changes in the tissue lining the esophagus. That's known as Barrett's esophagus. Barrett's esophagus. So it was Dr. Barrett who noticed years ago that chronic acid reflux disease often may lead to changes of cells in the lining of the esophagus. And Barrett's esophagus is a precancerous condition, so that it increases one's risk for esophagus cancer. Now, of all the 20 to 25% of patients who have chronic acid reflux in this country, only it was estimated about 5 to 7% will ever actually develop the Barrett's condition. But if it's there, it's important to watch that, because if that Barrett's, because it can evolve into cancer, sometimes if we can catch it early enough, we can do something to help reverse or treat that problem. There is sometimes a method where we go down with the endoscope again, and we treat that Barrett's with a burning device that burns the cells off the surface layer of the esophagus, and that can actually lead to development of normal, healthy livers, or normal and healthy esophageal cells again. So we can actually get rid of the Barrett's esophagus, and we often will do that if someone seems to be developing some tendency toward cancer. Now, often the Barrett's esophagus doesn't just turn into cancer, in one day, or rather, the Barrett's sometimes leads to low-grade abnormal cells, and then over time, high-grade abnormal cells, and then over time into cancer. So if we're monitoring that Barrett's condition by periodic endoscopy, we take biopsies of that Barrett's tissue and look for any signs of abnormal cells. And if that's identified, we often will recommend to proceed with that burning treatment to get rid of those abnormal cells. Now, cancer in the esophagus it's a bad disease. Right now, of all the cancers that we deal with, the one that seems to be increasing most rapidly is cancer of the esophagus. Overall, it's not a common cancer, but it is increasing. I should also mention that in individuals who have that Barrett's, they don't necessarily go through low-grade cell changes. They may one day go from normal Barrett's a year later to high-grade cell changes. So it's something that is not always predictable, and really it's something that needs to be watched as a way of avoiding complications from the Barrett's.
Well, if someone's found to have Barrett's, is there anything that can be done to prevent cancer from occurring?
Well, the most important thing is to stop the acid reflux, because the engine that drives the Barrett's into cancer is really the ongoing reflux of acid. So in anyone with Barrett's, the recommendation is that they should be on medication to reduce the acidity in the stomach. And if there's less acid generated in the stomach, there's less acid available for acid reflux. The second most important thing, if someone has that Barrett's condition, is to monitor it. So periodically we will advise patients to come in and have the endoscopy done and take biopsies so that we know if there's any abnormal cells or any early cancer cells that we can catch early enough to before anything much more serious will develop. Now, so Barrett's can be reversed to some extent with aggressive acid suppression. And we used to think that wasn't possible, but if someone has a very small area of the Barrett's, sometimes we may notice that may go away over time.
Well, what's the best way to treat GERD and prevent Barrett's?
Okay. Well, I seem to keep harping on this idea of the importance of weight reduction, but in fact, not only is that good for the fatty liver, but it's also good for patients with acid reflux. So the chest cavity naturally it's a low pressure cavity, and it has to be that way to allow air to exchange in and out. But once we move below the diaphragm, we enter the abdominal cavity, which is a higher pressure zone. And the only thing separating the barrier between the higher pressure in the abdomen and the lower pressure of the chest is your diaphragm and that sphincter in the lower esophagus. Now, if someone gains weight, they often gain that in and around the abdominal area. That just increases the abdominal pressure, and it makes it much easier for the acid to back up. So weight reduction goes a long way at helping to prevent the acid reflux. We also mentioned the importance of avoiding acidic foods and beverages. And then there are now medicines that have been around since about 1990 called the PPI medicines. PPIs are, many of you heard of that, I'm sure, are medicines to reduce the acid reduction in the stomach. That includes things like Nexium or Prilosec or Acifex, Protonix, and the like. If someone isn't interested in taking medicine on an ongoing basis, there are actually some surgical procedures that now are available, again, as more of a last resort for individuals to treat their chronic acid reflux. One of those procedures can be done laparoscopically. We call that a fundoplication, where the surgeon goes in and actually tightens up that sphincter and help reduce the acid reflux. There's also a newer procedure called a TIF procedure, where we actually can go in and tighten that sphincter endoscopically. So we can go with one of those scopes down the throat, and we can tighten up that valve in that way also.
Well, if they're not having surgery, is there any long-term effects for taking PPI medicines like Nexium and omeprazole?
Yeah, again, very good question, Dan. There's been concern about that for many years because there have been some studies that have suggested that long-term PPI use can lead to side effects. And some of those side effects have included weakening of the bones, such as osteoporosis. Some people have suggested it can increase risk of dementia. Some people used to think it can affect kidney function or affect the heart. Now, we've done a very, very thorough job at looking at all the world's data on long-term use of PPI therapy. And what we've confirmed is that we're not seeing long-term side effects from these medications, by and large. Now, there are individual exceptions, of course, but for the most part, these appear to be very effective medicines in terms of reducing acid reflux, reducing risk of Barrett's esophagus and complications of that. And it appears as though these are safe medications. But like all medicines, I often tell patients, look, the less medicine you take, the better. So do what you can in terms of lifestyle changes, including weight reduction, avoid overeating, avoid acidic foods and beverages, avoid late night meals. Maybe you could prop your head up when you sleep at night to minimize nocturnal acid reflux. And if you do need a PPI, sometimes maybe taking it every other day sometimes works well, or every third day. So the important thing is to control the acid reflux in some fashion, ideally without medicines, but if medicines are necessary, we have good options to help people.
Well, I appreciate that, Dr. Janda. I think we've learned a lot today, and I really appreciate you being here and going over these topics with us today.
Well, Dan, thank you for coming up with such excellent questions. I enjoyed our discussion today. Maybe someday we can do this again for Florida Gulf Coast University. Thank you all for listening, and hope to see you again sometime.